At present, we have around 600 neonatal units on the government sector, which is operational. And then, apart from this, we have at least 5 to 15 per district headquarters. So, with all this improvement in neonatal care, many premature babies survive even in the rural areas, and this has led to an increase in the incidence of ROP. However, the ground reality is that the awareness of ROP is low. And although we have trained ROP screening experts, they are available only in the urban areas, and in the rural they are really non-existent. Thus, there is a lack of providing ROP screening services in these areas. So, we came out with the Aravind ROP telescreening program. It's called the ROP SOS, and this project was funded by USA. The aim of this program is to screen 2,000 babies per year by doing ROP screening in underserved and rural areas. The team consists of two managers, 2 trained technicians, 1 mid-level ophthalmic assistant, and a driver. And we cover neonatal units in this 9 districts of our state, that is Tamil Nadu and the neighboring Kerala. This is a picture showing the districts which we cover, and when we started we had a memorandum of understanding with 53 neonatal units, 40 on the private sector and 13 on the government side. As far as the infrastructure, we have the RedCam shuttle, and then we did the technician training in 2 phases. In phase 1, they were trained using the RedCam imaging practice kit, and in phase 2, they did the imaging on babies in a pediatric retina unit under supervision by a retina consultant. We also customized a van to carry this RedCam machine, and this van also has the provision to carry a diode laser, and it also has provision to perform the laser inside the van itself. Images were transmitted to the base hospital using a modified address software which we developed in-house for a diabetic retinopathy study, but we modified it for ROP screening, and the connectivity was established using broadband internet, and central server was. This is how the modified address software looks like. This captures data on all the maternal and neonatal data, and then you can even store images. We also did a comprehensive eye screening in these premature babies. We used the RedCam to capture anterior segment images also. The project started on last year in August, until September 24th. We have screened around 3,328 babies, of which we found 529 babies, that is almost 16%, to have some form of ROP, and we found 50 babies with 95 eyes having severe ROP which needed treatment. Apart from this, we also saw 85 babies who had birth-related retinal hemorrhages. 1 which was not premature, but it was referred for leukocoria, had a retinoblastoma, and 5 had cataracts. As far as treatment, we did laser in 57 eyes, intravitreal Avastin injection in 34, Lucentis in 4. Vitrectomy in addition to laser was performed in 2 eyes. A repeat laser was given in 2, and a repeat Avastin in 2. We also developed posters, multicolor ROP posters, which we stick in the neonatal units, and also brochures which we distribute to the mothers of these premature babies. This was the case of bilateral retinoblastoma, which was referred to us, and the picture down shows the post-treatment. We also developed a software wherein we could send messages on the smartphone, on the phones, and this usually we give a reminder for the ROP follow-up visits, which is sent 1 day before their appointments. We also conducted continuing medical education programs. Till date, we have sensitized 375 neonatal units on ROP screening. The impact is that we sensitized the neonatal staff regarding the importance of using oxygen blenders, and we have seen a drastic drop as far as aggressive posterior ROP is concerned. This was a picture of an infant wherein it was during the initial part of our screening, and this was a baby with gestational age of 36 weeks and birth weight of 1,800 grams, which normally would fall outside our national guidelines. Also, of late we are seeing more parents demanding an eye evaluation of the newborn, and more healthcare providers also refer to the premature babies on time, and more ophthalmologists also get trained because of screening and management because of the increased referrals and demand. This is a short video of how we go about. Here you see the red cam being loaded into the van, and it is secured, and then we have the team. They leave the base hospital and then go to the rural areas. We have the van goes on to fixed places on every day. Almost we travel 6 days in a week, and it's all predetermined where we go every day. So right now, this team visits 18 towns regularly every week. This is one of the government neonatal units, wherein our team, which consists of a manager, 2 technicians, and 1 mid-level ophthalmic personnel. These people, they capture the images, and then they are transmitted to the base hospital. They are being transmitted by the manager to the base hospital, and these are at the base hospital. These are read by our pediatric retina specialist, and the report is sent back to the neonatal units, and the turnaround time is less than 15 minutes. And the neonatal units receives the report from the pediatric retina specialist, and the important thing is that we also do the counseling to the parents at on the same day. As far as costing, we have as far as the equipment is concerned, we have a RedCam shuttle with the van and the diode laser, and human resources. The retina consultant, he spends around 10% of his time for this. We have a project manager, a field coordinator, 2 ophthalmic technicians, and a driver. And the recurring costs involve the internet costs and the travel, and also the printing of brochures and conducting these CME programs. Equipment wise, the total fixed cost is around $65,000. Recurring cost, total recurring cost comes to around $9,000, and the total, if you compare it with the preterm babies we have screened, so far we have screened 3,328 babies. So the cost of detecting some form of ROP is around $529. But when it comes to the treatable ROP, it is around, it is even more. But when you translate it into the DALY's disability adjusted life years, I think this is worth it, and it goes a long way. Apart from this, we also do short-term ROP fellowships, and we are trained so far from 40 ophthalmologists, 35 in our country, and 5 from outside. So to summarize, early identification via telescreening goes a long way in preventing needless blindness. It also avoids the visit of an ophthalmologist unless it is indicated, wherein he has to go to do a laser, and also it increases the awareness amongst all neonatal staff and also amongst the providers. Thank you.
Great talk. And I really appreciate how you also looked at the human piece. It's not just throwing technology in a program. That's the problem. It has to be integrated with human resources, cost recovery. So that was a fantastic talk. Our next speaker is Dr. Lucy Mu.